So I'm pleased to be joined here. It's the second day at the AATS Mitral Conclave. Pleased to be joined by friend Dr. Greg Fischer. Greg is Chief of Cardiac Anesthesia in the Mount Sinai system, is that right?
That's correct, yes.
So you've been obviously intimately involved in not only the management of the patient in the OR, but the echo management of the patient in the OR. Greg, a question always comes up. You're in there. When do you need to go back and re-repair or fix MR that's in there after repair?
Yeah, that's probably one of the hardest things that you have to do. I lucky and blessed enough to work with Dave Adams,
right.
So we never have that problem at Mount Sinai,
yeah.
Obviously. But, no, in all seriousness, sometimes you do come off bypass and you do see a residual jet there, and I think you have to keep the fundamental principles of how you diagnose a mitral valve in mind, and there's really no difference to it. So it's sort of the Carpentier pathophysiological triad. You first look at the dysfunction, see if you can identify a dysfunction. And what I find very important is to also originate where the leak, where the regurgitant leak is coming from. Is it in the closure line or is it outside of the closure line?
Correct.
Because that plays a big important role. Any type of leak that you find outside of the closure line, leaflet perforation, something like that, you're generally going to be returning back to bypass.
Correct. Okay. And do you look, people are always saying, gee, is that closing volume? Do you see a little blurb of red there? Is that a common problem, or do you?
That is a common problem, and I do look with M mode quite frequently to see if I can trace it with color M mode to see if I can trace it throughout the systolic cycle.
Okay.
If it's early systole and then it goes away, those are jets which are usually not of much concern. You often see that when you come off the heart-lung machine, a little bit of air might have gone down the right coronary, the inferior wall might be lagging behind. So the optimal, coaptation between the two leaflets isn't perfect, so you might have this little bit of a closing jet or a small jet there. You wait 10, 15 minutes,
that goes away.
And that goes away when the ventricular function comes back.
So when you say inside or outside the closure line, are you talking about if it's at the base of one of the leaflets or if it's, periannular? It's not going to be around the ring or anything like that, are you?
One of the great things about this meeting for echocardiographers like you and me is that we actually get to see what the surgeon does, what the type of repair techniques. And if you understand the type of repair techniques that your surgeon employs, you already have sort of a differential diagnostic pathway laid out of what could happen. So, for example, if you're doing a large sliding plasty on the posterior leaflet, well, there's going to be a lot of suture lines in there. The leaflets are being detached from the base, and usually a quadrangular resection is done, which leads to a central suture line as well. So those are all possible areas where you could get a leak.
You want to look at all the suture lines.
Exactly.
Is what you're saying.
Whereas if, someone is doing a loop technique or something like that, a leaflet perforation is always possible, or residual cleft is possible, but it's not something from what the surgeon cut. So immediately knowing what the surgeon does, which techniques are being employed, helps you in your differential diagnosis.
Super. Quickly, you guys have been doing some interesting things on tricuspid. When to do a tricuspid annuloplasty? It's a big. While it's controversial, it's some people say never, some people say always.
Very controversial. I think, we looked at that Jill Dreyfus paper with the 7 centimeters. That was, of course, on a flaccid heart with his fingers going in there. At Sinai right now, we look at the 4 centimeter, the 40 millimeter rule. And one of the things which is interesting, though, is yourself how the tricuspid valve dilates lateral posteriorly. And we don't really have a very good conventional two-dimensional view to really capture that dimension of the valve. So what we have been doing at Sinai right now is we've been using three-dimensional echocardiography to capture the annulus, and then we've been measuring in that true, septal anterior to postero septal commissure.
Are you doing that above the diaphragm? So in a
That's correct.
Okay, so you're doing it in a 4-chamber view or something
That's
like
correct.
that, and then create.
That's correct.
That's cool.
That's
well,
correct.
Listen, I appreciate. I know you guys done super stuff up there, and you're educating your cardiac anesthesiology colleagues. You need to educate the echo colleagues too. Thanks very much, Greg.
Thanks
Good to
a lot,
see you.
Randy.
Thank you. Okay,
Pleasure.
good.
Thanks.
Super.